All right, everyone. I'm really excited for today's episode. I have on Dr. Bill Chun, and I followed him on Instagram a while ago, and really excited to see a doctor speaking out about some of the medical procedures that we're seeing happening in the birthing world, and some of the, I guess, not necessarily medical procedures, but the things that have become norm that maybe shouldn't be. So I was really excited to discover your page and to see how you have a passion for comprehensive gynecological care and following up with what the data is showing us, because we know that research takes a while to catch up. And unless it's the ARRIVE trial, then everybody just runs with it. So,
That's right.
it's really cool to hear you on yours be so passionate about spreading the messages that you do, and your approach with pregnancy. So I'm really excited for this podcast today. We're mostly going to focus on like inductions and a little bit of like the standards of procedures that happen when you're admitted to the hospital and what are your options during that. So I just want to thank you so much for your time and for coming on the podcast today.
Great. Thank you for having me.
Um,
So,
no, go ahead, dive right in.
yeah. So my name is Bill Chun. I'm a board certified OBGYN. I am out of Boston. Briefly, I'm an immigrant. I've lived in this country for 50 years, grew up in Ohio, spent some time in the Navy, and then got my education in Columbus, Ohio. Came to Boston in 89, did my training here. I've been in Boston for 30 some years now. I like my job. I think by accident, I found the right profession. And around the time the pandemic started, I studied this doc and doula and started to spend some time on social media and really about educating women. I have probably a bit of a unique practice where some of us in the country really believe that having a relationship with patients matter. So for the longest time, and I think probably my entire career, in the beginning was my pager number. Now it's my mobile number. So all my patients have my mobile number. And if you think about me being trained 30 some years ago, that was when induction rate was maybe 10%. My hospital wide cesarean section rate was 13%. Now I use one out of three women, at least one out of three women will undergo induction of labor. Another one out of three will undergo C-section. Maybe one out of three will experience spontaneous labor. And since 90% of birth in this country are attended by physicians, I really think we, the physicians, are at fault. And look, I just did not finish residency a few years ago. I've been doing this for 30 some years. And I have found the way I practice, it works. I have the lowest induction rate, I have the lowest cesarean section rate, and my patients are very happy. That's because I always emphasize communication as the main tool, and it works. Now, why isn't this happening across the country? Many reasons. I don't even know where to start, but we have a lot of work to do. And on Doc and Doula, right now I'm in the process of creating my own identity because I feel like with Doc and Doula, I love the concept because I started that because I believe that doula as a group may be the only possible hope in this country. What I mean by that is there aren't enough OBGYNs. As it is, there are enough of us doing harm. We need more midwives, but nothing's going to really change. But with the doula concept, this works. And I think we need more doulas. I think every laboring patient, prenatal, labor and delivery, postpartum should have doula. So I created Doc and Doula. Now, and I'm always known as a doc of Doc and Doula. So I decided, you know what, I need my own identity. It's like being a part of a very popular band. I'm going solo. So I just started Bill Chun, MD, as my own and started to post things, new content. And I think if there's one thing I can do is to help educate women, the public about no induction,
Mm.
why it is unnecessary. So I have 9-part no induction course, which I'm going to expand and really understand what normal pregnancy is like and why, unless there's a reason for the mother or the baby, why we need to leave you alone. And
Hmm.
it's common indication for induction, such as this AMA or advanced maternal age over the age of 35, or IVF, large baby, high BMI, gestational diabetes, control with diet,
Right.
medication. There's so many indications which, and you know this, Liz, if you look at American College of OBGYN or ACOG guidelines, they don't say 39 weeks. It's always a week or more. There's a range.
Hmm.
And why do we use 39 weeks? I mean, the ARRIVE trial it's idiotic, it's stupid, but apparently ACOG and Society of Maternal Fetal Medicine didn't think so. I think younger generation of OBGYNs really use that as a reference. I think it's wrong. Why? Because we don't really understand labor. We don't
Hmm.
understand pregnancy. I mean, I tell my patients that even after 30 some years, I don't understand uterus. I don't know. It's the mother nature. So as long as mother and the baby are doing well, I don't intervene. I don't do exams in the office. Unless really asked, I don't like to do stripping membranes or sweeping the cervix. I think if everything is going well and with close monitoring, women, regardless of the age, can be left alone until 42 weeks.
Yeah.
And Liz, most women go into labor at around 41 weeks.
Hmm.
So it's about, I try to really de-emphasize the importance of labor and delivery. It's pregnancy, it's 9 months. When patients come into my office, one of the first things I say is, you know what? Forget about pregnancy. Why should your life come to a halt just because you're pregnant? You have a life. Live a life. We'll watch you. Just do everything that you usually do. Because I think managing everyday stress and anxiety for 9 months is so important. At some point, we'll talk about what to do around the time we labor and delivery. More importantly, getting ready for their fourth trimester, which we don't do enough of.
Hmm.
But we have a lot of work to do to educate patients and provide them with resources like your podcast and your all the good you do, your blogs and whatnot, so that they can make really good shared decision making process with the support of good providers. Because I think there's still some of us who believe in the mission. I
Hmm.
mean, it's sad because I'm in Boston, or Mecca of medicine. But if you ask me right now, Liz, to come up with a 6 OBGYN that I can recommend in a minute, I would say, you know what? Let me have a drink first because I don't think I can come up with 6.
Hmm.
How is that possible when I'm in the business? When I'm in
Yeah.
Boston, I'm not in the middle of Mississippi. I'm in Boston. I can throw a stone, hit Mass General Hospital, Brigham, BI, Tufts Medical Center, but I cannot come up with a 6 OBGYN for you. You see
Right.
why? Because I know them,
Hmm.
right? See, once you let me talk, I keep talking. So you got to tell me to stop.
No, I love it. I mean, you're mentioning so many good things. I just did a post talking about like induction and saying like medically indicated inductions are not BMI, advanced maternal age, like all the things that you just listed, because so many people, though, they're like, okay, well, what does mitigate like a medical induction? But their providers are telling them that this does. They're saying, no, like in order to keep your baby safe, we need to do this. And so they're basically being fear-mongered into getting
Mm-hmm.
an induction instead of having any form of informed consent around it. And they're not giving the risks of induction along with it. Like you said, normally when we keep hands off, things turn out great.
Yes,
Um, are there times when you need to intervene? Sure. But right now
sure.
we're talking about the majority of births. If you let them go, they're fine. And that's just like not what we're seeing now. We're seeing the majority of births are highly intervened, like high intervention, a lot of inductions. I went to a birth here at a hospital. Well, I had the advantage. I'm not from the Chicago area. I live here now, but after I moved here, I got a job with a midwife group in a hospital. They hired 4 doulas. And
Wow,
so
amazing,
it was great. I got to work there
amazing.
for a couple of years. Then after I was pregnant with my second kid, I decided the on-call life was a little much at the time. So I've just taken on some private births since then. And so I was getting used to some of the hospitals here. And one that I went to, my client came in, she went into labor on her own, and the nurses were like, this is so fun. We never get to see this. Like the
Yeah,
majority of our
yeah,
births are inductions.
yeah,
And I was like, what? They're like, yeah, the majority are inductions. And I'm like, why? Like,
yeah.
why?
Why? Well, why? It's because we providers practice based on insecurity, fear, algorithm based. I first of all don't think young OBGYNs are being trained well enough. 4 years isn't enough. I wish somehow we could integrate midwifery into OBGYN residency. One of the benefits I've had was right after my residency was over, my first job, I had 3 strong-willed women, midwives, who retrained me. Right away, they said, Chun, episiotomy is not needed. Don't be tugging on that cord. Leave her be. Use lots of oil. Labor down. And so someone asked me, what is your episiotomy rate? I said, 0.
Yeah.
Last time I did an episiotomy, I think President Clinton was in the White House, which is mid-90s.
Oh my gosh.
And I mean, like, people say, well, you need it because of operative delivery with vacuum, forceps. Again, I don't really think vacuum and forceps are needed in most cases. I think I did one vacuum maybe once in the past 10 years. I have not used forceps since 90s. Even with that, I don't think episiotomy is needed. But so many of these things are taught and in theory, but you're right. Most young labor and delivery nurses have not seen spontaneous labor. I mean, typically, I usually have 2 to 3 out of hospital birth because my patients stay home and a lot of my patients drive. I had a really impressive delivery where they lived like 45 minutes from the hospital. Second baby, things really moved along. So I had to pull off the highway. I said, do you have a second phone? Yes. Well, keep this one on, call 911. And over the course of 11 minutes, she delivered in the car and EMT was there. I was so impressed. I wasn't even what impressed me more, that husband was calm or that EMT got there in 11 minutes.
Mm-hmm.
And everyone was fine because many babies are born around the world without being in a labor and delivery room.
Yeah.
Right? I mean, my mother got pregnant when she was 15 and she had me at home because this was just shortly after the Korean War. She had no prenatal care. She was malnourished. She's not sure how many months I was. And she said, only thing she can remember is that I had a big head and that my grandmother was there. And you know what? Luckily, I survived. And I find it ironic that that is the beginning of my life. And here I am in Boston. I'm an OBGYN and talking about how poorly we treat women in Boston. How can we justify 1 out of 3 cesarean section rate? How can we justify such high induction rate? It's one thing, Liz, if I say, I am so good at induction, I'm going to bring you in, I can time the delivery. That ain't so.
Right.
So because we are using the same method that I was taught as a resident 30 some years ago, before the age of cell phone, the methods we are using now are the same. Only thing we are using now that we really didn't in the back then was always balloon or Foley catheter, which I do not like because I believe cervical ripening method is usually chemical, and I think the balloon really is uncomfortable. And all the studies have shown that different prostaglandins and the Foley catheter when it comes to cervical ripening, data is the same. And then we use the same Pitocin. So we don't have anything new. We have iPhone 16, but we don't have anything new with induction. So why do we do this? I think because a lot of providers don't have a relationship with their patients. I mean, you know this, a lot of patients are being seen by a group of providers when they go into labor or being brought in for induction. It's usually a group of providers because we work 12-hour shifts. You know, Dr. Chun is covering for 6, 7 other doctors. Patient comes in for induction. Oh, she's 36 years old, IVF, first-time mom. So her indication is she's over the age of 35, IVF. Okay, well, hi, my name is Dr. Chun. Liz, nice to meet you. I was told by your doctor that you're being induced. So here are the methods. I don't know what your doctor said, but I like to use this because I don't really care what your doctor said. I'm going to do what I prefer. Oh, by the way, I'm going to give you medication by mouth, and someone else will come in because my shift is over. Someone else comes in. So this goes, I mean, I have seen patients trying to be induced for 7 days and end up with a C-section. Because by the 7th day, the patient who was brought in for that very reason of being 36 in IVF, she's not going to go home. My doctor brought me in because of risk. I'm not going home. It took me 3 years to get pregnant. I just want my baby. So the patient is very vulnerable because on 7th day, doctor says, you know what? Induction is not working. And we should probably do a C-section. Oh, okay, doctor, because I don't care what happens to me. I just want a healthy baby. That happens all the time.
Right.
And shame on her prenatal care provider. Shame on all the doctors who should have said maybe on day 2, you know what, Liz, it's not working. Maybe we take a little break.
Right.
Maybe you come back because we had you on monitor 24/7. Everything looked good. Why should we continue this? Oh, by the way, the doctor didn't say, if I do a C-section, I get paid 15% more. So let's just get it over with.
Yeah.
So it's partly the system with hospital, insurance companies, providers, and lack of adequate information, because we do have a lot of patients who are well informed.
Right.
I mean, a lot of patients know how to say no, because I want people to be able to say no. No means no. No induction. So that's your job. That's my job to say there should be at least 2 options. I like telling a story of this first-time healthcare professional IVF on 40th week on a Friday, at which time I usually like to do an ultrasound since it's weekend. I just want to make sure the fluid is fine. On ultrasound, there was no fluid, 0. So I say, hey, by the way, you know, baby looks great, but there's no amniotic fluid. In cases like this, recommendations are that we should probably have you go to the hospital, get you hydrated with IV fluid, and then maybe consider starting the process of cervical ripening and induction. And the patient was smart. She goes, let me go home and talk to my husband first. Sure, go ahead. She calls me, you know, Bill, we talked and we think we just want to, I mean, I promised I drink a lot, but we just want to see how it goes. I said, okay. So I'm having a little angina. I said, okay. So next day, we spoke a couple of times and she said, yeah, baby's moving. I've been drinking. There's nothing. Sunday evening, she came in labor. She was like 3 to 4 centimeters. She had a nice vaginal delivery. I believe 99 out of 100 providers would have had on Friday had or signed against medical advice form, which I could have too, but I think they would have broken our relationship. They would have raised her anxiety, and I don't think she would have had vaginal delivery.
Yeah.
Because I always say, and this is where I think I differ from a lot of providers, my job is to provide you with information. Your job is to pick one or the other. And then it's my job is to support you. As long as I gave you enough information, helped you with your decision-making process, then I did my part. My job isn't to say, well, baby might die. Because that's what a lot of, stillbirth. Stillbirth is like saying I love you. So many doctors say stillbirth, stillbirth. Gee. So the problem lies with providers, particularly OBGYNs. We do 90% of birth in this country. We do all the C-sections. No midwives do C-sections. We're doing over 1 million C-sections in this country. Most of them caused by us.
Right.
And I know if insurance companies said, if you do a C-section, we're going to review your case. If it's not justified, we're going to pay you 85% of vaginal delivery. I bet you our C-section rate goes down
Oh,
because
yeah, for
it'll
sure.
hit our pocket, right? But
Mm-hmm.
that's not going to change either. Because
Mm-hmm.
if a hospital has a 30% C-section rate and wants to reduce 20%, I'm the CEO. Why would I? Because for every 100 vaginal deliveries compared to C-section, it's 20,000 versus 30, 40,000. For every 100 birth, it's $1 to $2 million.
Right.
I need that revenue. So as long as no one's complaining, I don't care about leapfrog rating. Who cares? I need the revenue. That's the country we live in. And
Right.
it has to change
Mm-hmm.
because you're going to speak louder and say, no, 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 no. I'm going to do my part and we'll have a choir. We all say, no, 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 no. No, 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 induction. I mean, of course, there are inductions which are necessary.
Right. Right.
Preeclampsia,
Mm-hmm.
right? Anything with mother, high blood pressure related, diabetes, pre-existing or gestation diabetes not under good control. Sure. Intrahepatic cholestasis. Sure. For the baby is fetal growth restriction or baby doesn't look good on monitoring. Sure. But it's not 1 out of 3.
Right.
It really isn't.
Right. The issues run so deep, and like you touched on a lot of them, because it's like it's not just the providers, it's also the insurance companies, and you have to see 30 patients a day and you have to like do all these things. So it makes it harder to have that relationship with your patient. It goes very deep. It's just messed up on a whole. Um, and I can see why, you said people, that client was like 45 minutes from you, like why you're a sought out provider, because like the things that you're saying, um, like even where I live outside Chicago, people ask me like who I refer to, and like I really don't have an OB here that I refer patients to. And I
Mm,
recently got to work with one that a lot of people have referred to. I've never had a birth with him before. He's really the only provider in the area that will do a vaginal birth after 2 C-sections.
mm,
And the birth that I was with him was close to one of the most traumatic births I've ever attended.
mm,
He played the dead baby card. He came in, he wanted to check her every 30 minutes. She went into labor on her own. It was awful. And after he checked her, she was 7 centimeters dilated. An hour later, she was 9 centimeters dilated. He comes back, wants to check her, and she denies, and he plays the dead baby card and chews her out, like goes crazy. And then basically told her like she's gonna have a dead baby. He never should have let her labor this long. Like it was just, there were so many things. There was no informed
mm.
consent on so many things that happen. And I'm like, he's the only one in the area that will attempt a vaginal birth after 2 C-sections. And my experience with him was terrible. And
I
I'm like,
mean,
who do I refer these women to? Like, that's
you
the hard
know,
part.
I I remember as a medical student, we get to choose different. I mean, we get to rotate through every specialty to see what will attract us. And I remember orthopedic was below the knee amputation. I said, "Oh my God, no!" Plastic surgery, mastectomy. Oh God, no! So one by one, and then I saw this um, young resident, just very good with his patient, and I thought delivery was like, wow. And I just kind of fell in love with that. And then I came to Boston and did the 2 electives, and really just to make sure this is what I wanted to do. It's a privilege. I mean, why do I give out my phone number? Because I want to make sure my patient has a positive experience. To me, positive experience just isn't labor and delivery. It's me getting I try to see my patient around 7 weeks because a lot of stuff happens at 7 weeks and on.
Mm-hmm.
And first time mom, you need information. What can I eat? What can I do? What is normal? When do I call? Because I always say the first trimester is all about surviving.
Yeah.
Little alien invasion, and your body is trying to figure out what to do. It doesn't matter what you eat, or just forget it, just survive with helpful information. And then there's the second trimester, there's third trimester. And I always talk about how your simple life, Liz, before your first baby, life was simple. And then you had a baby, then your life was over. You did it
Yeah.
3 times. Oh my God. I have 5 kids. I did it 5 times. My simple life is over. But the process to be part of that, it's a privilege. I want to make sure every one of my patients understand what it means to be a parent. And it's going to be hard enough. Therefore, the process and beyond, I want to make sure everything was done accordingly so that they have the best chance with the beginning of life. I believe in that. And I think that's kind of what I wrote in my medical school admission essay. I want to help people. And I believe that. And I got very lucky because, I mean, for me, it was either this or Chinese restaurant. You know, otherwise I would smell like, God, I smell like egg roll every day. But I got into this specialty and I'm so lucky because I have such loyal patients.
Yeah.
My office is like UN. I have patients from 70 different countries and they are the nicest people.
Yeah.
And we get to know each other. They often ask me, hey, how are your kids? Patients are asking me because I talk about my beginning, my family, my kids. And just by having my phone number, 99% of my patients do not bother me. It's
Yeah.
1% of my patients who they do all the, like 99% of all the annoying stuff. But
Yeah.
patients, I get it because patients get hold of you because they need help.
Yeah.
If my 1 minute conversation can ease the anxiety, I think my social media person is posting my phone number on my account tomorrow. That's why not? Who cares? I don't care. I mean, so if I think about that, if we, the providers, really took this job seriously, I think we'll do better.
Yeah.
Unfortunately, many of us pick the wrong profession. And what are you going to do? If you're unhappy, what are you going to do? You just kind of get through it, right? I mean, life, you have student loans, blah, blah, blah. And it's hard to change a career after being a doctor.
Yeah.
But I think what we need to do, Liz, is talk like this over and over, talk over social media, cyberspace, in person. And all of us need to come together. You know, we should have like annual get together in virtual space. And again, what can we do so that we can help women in Chicago, Boston, Mississippi, blah, blah, blah. We are fortunate enough that we have the resources we have because where we live. And of
Mm-hmm.
course, there are plenty of places, desert, lack of. And I don't know. I pick my battles. What can I do? I'm just
Yeah.
trying to help women in my area, you know?
Right.
And but I have 4 amazing support people. From the person, very first phone call is answered by Blanca, secretary, Jennifer. I have an amazing sonographer. I have a nurse who's been working with me for 20 years. And every visit, we make sure you are cared for.
Mm-hmm.
And if we did that, and you mentioned 30 patients, I don't really like to see 30 patients a day.
Yeah.
It's too much because I never bring in my laptop to a room. I just talk. I want to look at the white of your eyes and you of mine. We have a conversation. Sometimes it's 30 minutes, the other day. It was unfortunately like an hour, but we needed an hour. So I
Yeah.
went a little late. So by doing that, I think quality is important. And it's it's I don't know very many people who, having done this for 30 some years, who feel like, yeah, I picked the right profession. I like it. I can do this for a few more years. And
Hmm.
I'm excited because, I had a doc and doula. Now it's Bill Chun. I partner with Hihi, Tranquility by Hihi. We
Yeah.
created Birth Brigade. And at Birth Brigade, we're going to be doing this.
Yeah.
We think we can do better. So
Yeah.
we'll be talking about this over and over. We'll have guests. We should have you on as a podcast guest and talk about what can we do so that we can serve women better,
Yeah. I love that you
right?
mentioned like, kind of some sort of like virtual summits. I'm like, yes, like how do we all
Yeah,
get together to
we
like
need to get together.
do this? Because it's like, man, I need, even though I live in the Chicago area, I need more resources here. Like I need to connect with more people here. I need more good people to like refer out for different things to like know, hopefully get some OBs in on it. Cause like what you said at the beginning, like that doulas can make such a difference. And I actually interviewed a few months ago. She's a high risk OBGYN, and she was saying that how much she loves doulas because um, she knows that her clients are feeling validated and heard and that they're there, if she has another labor or something to check in on, that they're a constant that's there. And she's like, we need that teamwork. And I believe that. I'm like, I want to work with you, but so many times when I go into a hospital room, I feel like I'm working against you. And I don't want to feel
Yes.
that way. Like I've been steamrolled by nurses, by providers, like me telling my like I the other day I was at a birth and the nurse mentioned, we're going to see how baby does and we might have to use the forceps. And my client looks at me and goes, what are the risks of forceps? And I go to open my mouth and the nurse just like shut me down and was like, listen, like put her hand up and was like, listen, your provider will talk about this with you if it comes to that. And I was just like, can this lady please leave the room so I can just like have a
Yeah.
candid conversation with my client because I just like so many things I suggested, she was shutting down. Like baby was getting stuck. I'm like, let's get on hands and knees. Like they were fighting me on so many things. And I'm like, listen, like I'm not, I know you think that I'm just like uneducated and whatever because I don't have a MD or I don't have my RN, like, but I've actually studied this,
Yeah.
like I'm so
Yeah.
passionate about this and I'm here to help. I'm not
Yeah.
here to hurt. And doctors should love us because when a doula is present, they have a better feeling, better satisfaction rates. Even if the
Yeah.
birth doesn't go as planned, we make you look good. So it's like, let's work together. Like, how can we do this? But I've just like been, I've thankfully been welcomed with open arms at a lot. And at some just been like, wow, like I hope I might not take another client at this hospital because I've had so many bad
Mm,
experiences there. And that sucks because they need doulas,
yeah.
you know? And it's like, man, yeah, can you get a new provider and then I'll be your doula because I'm not working with this practice again?
So he and I, we are hoping to work with a local hospital. And our plan is to study the hospital, the maternity service over a few months, and come up with a plan to create a midwifery practice
Mm-hmm.
with he and I supporting their practice. Because I would like to have a maternity service that's all inclusive. So if you came to our hospital, oh, you registered as a new patient, or you will because you're on the Chun. I see you just study your prenatal care. From then on, anything you need, I'm going to give you a menu. So it's from appetizer to salad to main dish, dessert, anything and everything you need. Working with providers, experts, we approve. From pelvic floor therapists to doulas, we'll have Birth Brigade approved list of experts and really help you get through the pregnancy, enjoy labor and delivery, and get ready for postpartum so that you're not just forgotten as, oh, that's Johnny's mom. She just said Johnny. No, no, no. I always tell patients, once the baby's out, I don't care about the little baby. You're my important person because I got to help you so that you can recover. I mean, I saw patients today. Her baby, I think, is 6 months. I see her once a month right now, and I think one more visit because I think by next month she'll be able to go back to work because no one prepares you for the life after birth.
Mm-hmm.
And it is not 6 weeks.
No.
I don't even know where 6 weeks came along
Mm-hmm.
because some of you need 6 months. I think 3 months ago, we wrote a letter for a person who delivered with me 3 years ago because she never recovered. So all this stuff is what we're interested in. That's why, when you mention all this, we all need to come together because what works in Chicago may work here and vice versa, and maybe we need to fix things because
right.
more of us need to come together because there are too many obstacles between women and where they need to be because
right.
no one cares. It's all about money.
Right.
I mean, remember that drug that for injectable medication that they wanted to use for postpartum depression, like $25,000 or something? It's all about money.
Right.
And I think that the doula concept is amazing. You and I may not agree because I think doula should be regulated, but that's a topic for another time. But we can do much better. And man, I see a lot of OBGYNs, they don't really understand the art of labor management.
Right.
So if we talk about what happens with admission, labor, and delivery, it depends. If it's my patient, I know exactly what she needs, and we'll see how she does because I think less is more. I mean, there are often patients where maybe once the patient is admitted, questions asked, blood's drawn, and maybe IV is needed, maybe not. It's needed if she is in labor and GBS positive. If not, maybe we can hold off, especially if the patient is interested in unmedicated. I'm not really sure why she needs an IV access. Leave her alone. And a lot of nurses will say, oh, you didn't make it easier for me to draw the blood and place. Oh, you're being butt lazy. Forget it. Just draw the blood. She doesn't need that IV with a, and then after going over the history, adequate monitoring, at some point, maybe exam is needed, maybe not. I don't like to, if I think patient is active labor, I think you could just leave her be. She's going to let you know when you need to check her. We already know that Friedman curve that we used in 90s was wrong. And then another, study came out in, 2002? Maybe, I don't know. But I think that study really confirmed my suspicion in that there's like a range. We don't really know what this is. So if a person is 7 centimeter, like you're telling me about, I don't really want to examine her. I think I want to go take a nap.
Yeah.
She let me know. Oh, and I don't really like to have my nursing staff check my patients. And I always tell my patients, you should always be asked before each exam and learn to say no, because a lot of exams are not needed.
Right.
That's why infection and the cervical, we had 3 babies. It's uncomfortable.
Right.
I use that empty toilet paper tube as a tool. That's my favorite tool. I say, look at that. This is the average length of the vagina. And I collapse it. I have an average size hand. And for me to go into the tube and reach at the end, I got to put the pressure. It's not comfortable. Right. Why do I want to do it? So less exam, the better. And if a patient has a birth plan, should be respected. And I tell patients, if you have 10 things on your list, if you get 5 out of 10, then that was a good plan. You're not going to get all 10, 5 out of 10. But my patients are often labeled as, oh, Chun's patients are, so demanding. Oh, you
Yeah.
mean they're informed?
Right.
Because I make sure all my patients take classes and I
Mhm.
go over things over and over.
Right.
Because you're going to do this, go through the most amazing life experience, it's better be according to you, not me. So we're going to
Hmm.
get the education, come up with a plan. I'm going to do my best to make sure your plan is respected. And so the question about what's a standard exam or the process, it varies because many patients go to hospital where laborist, who's a
Right.
total stranger,
Right.
right? He or she has a plan and going to say, oh, it doesn't really matter. Birth plan, just forget it. This is how I do it.
Yeah.
And often patients are too timid to really express what's going on.
Right.
But if she had you, you're going to say, well, Dr. Chun, we have a plan,
Right, right. Well, I
right?
educate like a lot of people on it though. So I have a birth plan prep course. So I go
Mhm.
over each of these things and I always say I'm such a huge fan of birth plans. And the point isn't for the plan to go perfectly.
Yeah.
The point is for you to get educated and informed. So when a
Mhm.
decision needs to be made, you know alternatives, you know other things to do, you're just not blindsided by this thing, that you're still a part of the decision making and you can be flexible because you know, you know. Um,
Yeah.
and so one thing in the course that I talk about is like upon admission, and I'm glad you brought up like the IV thing, because that was something that I dealt with. And with my first birth, I birthed at the hospital that I worked with the midwives. I, knew a lot of people there and she fought me on not the midwife, the nurse fought me on the IV. And I was like, no, I'm okay. Like, I don't do well with needles. I don't do well with things in me. And she's like, I have to put it in. And I go, no, you don't. She goes, yes, I do. And I go, no, you don't. We literally argued for like a couple of minutes till my midwife came in and she goes, she doesn't have to have the IV if she doesn't want. And the nurse like
Yeah.
rolled her eyes and walked off. And I'm like, man, like I'm trying to educate on you have a choice here. But when women are pulling up into labor, into triage, they're not given a choice. And the one thing that I'm getting a lot of feedback on is the cervical exams
Yeah.
that they roll up and then like I was just at a recent birth where she did not want any, but they told her like this one hospital here, it's like we cannot check you in until you are at least 4 centimeters dilated. So
That's stupid.
right. So they're telling these
Duh.
women, we will not give you a room until you let us check you. I can't give you a room until I check you. I cannot call
Wow.
your doctor until I check you. So that's zero informed consent there because I can't consent to something. Like if I'm like, I don't want one, but then you're
Yeah.
denying me care based on
Yeah.
that. Like do you have any words of advice of things I can say to these women to like empower them to say something? Like how do they fight back on this? Like I know, like this is my third kid, the one that I was just at, it's her third baby. She was in active labor. Like she got there, she was 7 centimeters dilated because they had to do the check before she got to her room. She's obviously in active labor. You do not need to stick your hands in her vagina to figure this out. Like
Yeah.
I get so pissed off because I'm like, she wanted an untouched, undisturbed labor,
Yeah.
and we couldn't even give her that. Like,
I mean, I think she should have picked the different provider, different hospital. I mean,
right,
if I'm the chairperson in that hospital, it's embarrassing. Why do you think everyone needs something? And why does person have to be 4 centimeter? Because person who's having um,
right.
first pregnancy may not be dealing with her contraction pattern well, and she might just be a fingertip. And
Yeah,
maybe some people have traumatic experience where only absolutely needed exam because of history of trauma.
right.
So this kind of blanket treatment is what is wrong. And isn't it amazing that sometimes you have these very combative nurse? You think, why? You're like, shouldn't you be more supportive of women? But you have those nurses. I get into trouble because I often say, "Hey, I'm on my way. Who's my nurse?" And say, "Oh, that's say Jane. Oh, who else is there? Because I don't really want Jane to touch my patients, you know. And I got spoken to more than once and said, Chun, this is not your labor and delivery. You cannot pick and choose. I said, yes, I can. You
Hmm.
cannot. Well, yes, I can, because I don't want certain patients to touch my patients.
Yeah.
I'm certain nurses. And why? Because some of you suck.
Yeah.
It's that simple.
Hmm.
And but having a rigid protocol for anything is just wrong. And in that case, I think there isn't much the patient can do, because the patient is already in a very vulnerable state. But it should not be the case. And the
Right.
provider should have called and said, "Hey, Liz, Mary's coming in. Sounds like she's in labor. I know her very well, and it is very important for her that she does not get an exam until I get there. So
Yeah.
just do your usual thing. Oh, by the way, her GBS is negative, and I'm not really worried about postpartum hemorrhage. So let's leave the IV access off." Then there's no problem. Because if I said that and I get there and things were not done as I had asked, then someone's going to be in trouble,
Yeah.
because I have to look out for the patient, and the labor and delivery staff, they have to do the same, because that's my patient.
Hmm.
So I think that provider really needs to support. But the problem is, a lot of practice, they take calls like 1 out of 10.
Yeah.
And I get a call and, oh, okay, it sounds like, yeah, go to the hospital. And then I don't bother to call labor and delivery. I know nothing about this patient, but the patient thinks, oh, I have this plan. My
Right.
doctor's on vacation. No one's looking out for me. Then from the get-go, now this is a traumatic experience.
Yeah.
And that happens all the time.
Right.
That's why you are needed, because you are going to be the buffer.
Yeah.
And when
But
I tell
also,
people, yeah,
oh no, I was just gonna say also most hospitals here, like they will not let the doula into triage either. So like all the births
that's
I've gone to
stupid.
in the last 2 years, I have not been allowed in triage.
That's
So
stupid.
pretty much ever since COVID, I don't know if it
Yeah.
was different before that here because like I said, I'm not from here and I worked at the hospital for a while, so ours was a little bit different there. But yeah, I'm not allowed in triage. And so I'm literally usually texting their partner the
Mm-hmm.
whole time when they're in triage. And, like the birth that this just happened at, I was like, talk to your provider. She was with midwives at a hospital here. And I was like, talk to your midwife, go over it with them, say, put it in my chart. I don't need a cervical exam upon admission. Talk to them about your concerns. But still, she was coerced there.
Mm,
And the midwife wanted to do a check when she was there for literally no reason. So
mm,
it's like I'm at a point where I'm getting so exhausted going to these births,
mm.
like that.
You should be like he. Be selective
Yeah, I am more now.
and charge more money. So only
Yeah.
ones who really want you come to you and have their relationship. Um, but this has to be fixed. And it
Yeah.
won't be fixed unless it's mentioned. I mean,
Right.
we have reviews of Chinese restaurants, right? I mean, oh, don't go to Lucky Chun, the restaurant. The food sucks, delivery is never on time, and food is always soggy. Blah blah blah. You have to talk about it, and I talk about it all the time. Local hospital. I think the previous CEO was monitoring what I was posting, because sometimes I get an email like, "What are you talking about?" Blah blah blah. I say, oh, well, I'm a solo practitioner who brings you business,
Yeah.
and I'm going to do things for my patients. I don't work for you. I bring you business for which you do nothing for. I do the marketing. I bring you business. Patients come to me because how I practice. And, if someone is willing to drive hour and a half each way because she wants a trial of labor after 2 C-section, then I'm going to make sure she is supported.
Yeah. Right.
And I think that it is hard being a provider in 2024. It really is hard. This is when my daughter, who who came home to Boston from Philadelphia tonight. I can't wait to see her tomorrow. When she said, Daddy, I'm going to go to law school instead of medical school. I said, thank you, because I didn't want to watch her struggle. But for us, we believe in our mission and we have to speak up. Eventually, I think this will catch up, at least locally. So he and I are going to make, I think, this work in a local hospital, prove our concept to be of something that can be replicated in other areas, because 90-10 ratio has to be reversed. It's got to be, I mean, I don't know, within my lifetime, I don't know what it's going to be, but it's got to be more than 10% of birth by midwives. Otherwise, women will continue to be abused.
Yeah.
Abused, that I'm saying. I mean, that's a tough word, but that's what's happening, because why birth trauma stories are so popular. It's like crime junkies. Jesus.
Yeah.
Everyone. I mean, I had this one patient who, because of what happened in a local teaching hospital, she said she's not going to have another baby, even though she wanted large babies. I mean, imagine that. So, and I talked to, and maybe we can do something about virtual summit.
Yeah, for real. I know. Well,
Yeah,
when you're just talking, I was like, man, I feel like it'd also almost be cool to like start like a doula debrief, because even just talking about this like with other doulas in the area and talking about our experiences and then coming up with, then I feel like you start to learn who you had good experiences to and how could we maybe reach out to this OB and how could we like tell them like, hey, like we're on the same team. Like I want to be able to refer clients to you that are
yeah,
coming in who don't want a cervical exam, who don't want an IV. They're going to be very well informed and educated, and I cannot refer, I'm limited on options. I would love for you to be that OB that is
yeah,
supporting these
yeah.
women who want a hands-off hospital birth and try to come up with that, because I live outside Chicago and I know no one. Like
Yeah,
like you said in Boston, you can't come up with six. Like you can't, there's not anyone here that really has a hands-off birth. I'm sure that there are, like maybe I don't know of them yet. Obviously, there's tons of hospitals and providers here. I have not witnessed one. A lot of my friends in the industry have not either. And the stories that I get in my inbox every single day tell
I
me
mean,
opposite.
I have interesting patients. I mean, I had one patient who said, Sean, I only want one ultrasound because my cycle is regular. I said, okay. By the way, I really don't want to come can I come like once a month? Yeah, sure. I think I saw it 3 times. And she labored at home and she delivered. I think she went home the same day.
Yeah.
I have many patients who go back to their home. So sometimes, like I had more than one who would start the prenatal visit with me, and the patient would say, I'm going back to home. Where's your home? Uganda. Oh, you mean like far in? Yeah. When will you be back? I don't know, 3 months. So
Jeez.
I think I send her home with hey, here's an extra fetal monitor and blood pressure cuff. Let's do WhatsApp.
Yeah.
We can do so much. I have
Yeah.
another one right now. I just got done with she's very healthy, well informed. She did not want NIPT, she did not want NT. And I think I'm seeing her. So she's 12 weeks. I think I'm seeing her in 2 months. She's gonna
Yeah.
come in for an anatomy scan. And I think I'll probably see her once a month. In between, we're gonna come up with a plan, but we stay connected. And there's so many things we can do because she knows what she wants. She trusts me. I trust our relationship. We have a thing called cell phone, Wi-Fi. We don't have to breathe the same air.
Yeah.
And I am supporting what she wants to do.
Right.
And this can be done anywhere and everywhere. And I've past year has been very interesting because I've been supporting women in other states and other countries. My biggest challenge is finding figuring out the time zone because
Right.
of 12, 13 hours difference, right?
Right.
But women everywhere, Pakistan, India, England, Canada, other Asian countries have the same problem.
Yeah.
They're not being heard.
Right.
So I like the idea of many of us kind of coming together and figure out how can we make our voices be heard? What are the top three things we need? Can we really talk, share our experience, and come up with some agendas we can push, make them more public, and keep at it? I had a really nice email from young OBGYN out of Utah who I guess has been following me. And wow, I was so touched because he had said a lot of positive stuff. And wow, if I could influence one young OBGYN just starting out, then I think I did my job
Yeah.
because we can do so much better.
Right.
We're not a third world country. We
Right.
spend more money on healthcare than anyone. $14,000 for every American is spent on healthcare. That's almost twice as much as number two, Germany.
Mm.
And look at what are we talking about? We're not talking about how great our experience has been.
Right.
We're talking just the opposite. So I applaud your work because it looks like you have like 40,000 more followers than me.
I don't think so.
But um, let's keep talking and
Yeah.
we should stay connected.
Hmm.
And I'm going to send you my phone number. So anytime, anything, or just want to say hi, just text me.
Yeah.
Yeah, we should
Yeah.
stay connected.
I
This is
would love
good.
that. Well, I just want to thank you too, because like a lot of what I'm hearing from you is that like it's not about even your personal beliefs in even like what you obviously you're going to give your patients your recommendations, but when they have, like you said, they know what they want, you're supporting them and you're trusting the process. Like
Yeah,
we have this like thing where we're just supposed to blindly trust a doctor, but you're also supposed to like trust in our instincts. We know
yeah,
our bodies. I've been
yeah,
living in this body for 37 years. Like
yeah.
I know it pretty well.
Wow, you
And
look
so
good. You don't look 37. You
thank
look
you. Thank you.
good.
It's the lighting in here.
Ah,
But like I have something to say too. Like
yeah,
I have to intuition. I have, gut feelings. I have instincts and I have information. So that that give and take relationship where you're trusting in your patients too is like so amazing to hear. And I'm so glad that we got to have this conversation. I'm looking
yes,
forward to staying connected.
yes.
Before we wrap up, can you just let people know where to find and follow you, connect with you more? And then I will also link it all in the show notes to make it really easy.
Just started Bill Chun MD on Instagram and TikTok. Um, and my phone number, anyone actually is welcome to text me, 978-914-4809.
Okay.
You and others just text me. I, you know, it's a privilege. It really is. Every new patient who comes to my office or connection through cyberspace, it's a privilege. So it is important that I do my part. And I have learned it's always about listening more than talking. And I'm comfortable with my limitation because I'm actually more of a GYN than I'm OB because I like to operate. Um, and with GYN, when I do robotic surgery, I have to be in control. With obstetrics, I have learned if I just react to what's going on, then the outcomes are usually positive. So the balance between being an obstetrician and a gynecologist, it's two different worlds. And I am so lucky to have had this career. And I think I'm good for a few more years. So I'll be around. So just stay connected, Liz.
You
And
have to. You have
thank
to
you
keep
for
going.
and thank you for all you do, really. And I'm sure we will meet in person.
Yeah, I would love that. That'd be so great.
Yes.
That'd be great.
Great.
Awesome. Well, thank you again for your time and energy for making it more to come on. I know that you're obviously a very busy man. I mean, you just gave your your number out to
That's
thousands of
okay.
people. And so I know that you're very sought after. So I was really excited that you agreed to come on the show. So thank you again so much for your time.
Hey, if I'm coming to Chicago next time, I'm going to visit you.
Yeah, let me know.
Yeah. All
Yeah,
right. Take care.
definitely. Yeah, you
Good
too.
night.
Bye.